Here you can see a rather large biopsy. It may be an excisional biopsy. Looks like it's targeting a melanocytic lesion. And you can appreciate it looks to be composed of junctional and dermal melanocytes. Now, the interesting thing about these melanocytes are they have abundant eosinophilic cytoplasm here. And that's something you'll often see in a Spitz nevus. You may also appreciate that some of the nuclei appear bizarrely shaped. So you can notice some pretty prominent nucleoli as well. So just to give you kind of a overview here, it's large epithelioid melanocytes with abundant eosinophilic cytoplasm, prominent nucleoli. You might find an occasional mitotic figure if you look around long enough, but mostly it's not mitotically active. And so the point of this video is to really just review some of the immunostains that you might use to work this up. Now, I don't have the immunostains for this particular case, but we will just discuss. So the first thing that you'd probably want to do is assess the proliferation rate. So you could do a Ki-67 coupled with the melan-A stain. So the melan-A will highlight melanocytes in the cytoplasm, and the Ki-67 will stain the nuclei of cells that are proliferative. So you should get worried about anything greater than 5%, approaching 10%. So it's nice to visualize the proliferative activity of a lesion such as this. And typically these lesions are clinically growing in a young patient. So you definitely want to make sure the proliferation rate is low at the time of the sampling. The next stain that you'll consider is a P16 stain. So these are often retained in benign melanocytic proliferations. Now it's not 100%, but if you have broad retention of P16, then it's somewhat supportive of benignity. So that would be a useful immunohistochemical stain to do. Next is going to be PRAME. So PRAME has been shown to have pretty good alignment with molecular testing for Spitz nevi. Now, again, it's not perfect, and you don't want to put all of your eggs in one basket when it comes to an immunohistochemical stain. But PRAME is typically negative in benign Spitz nevi. And when we say negative, we say less than 75% of the cells are staining. But in my experience, benign Spitz nevi have much closer to 10% or less PRAME positivity. There are some nice papers out there that you can look at. Lexano et al. Has done a great job at researching PRAME. And if it comes back diffusely positive in a lesion like this, you'd want to definitely do molecular testing. If it comes back negative and the other stains are reassuring along with the histology, then you should feel pretty good about it. Next is BRAF V600E stain. So usually the nevi, the Spitz nevi, are negative for BRAF V600E. So normal nevi and melanoma can have the BRAF V600E mutation, but Spitz nevi, by definition, should be negative for BRAF V600E mutation. If you find positivity in a lesion like this for the V600E mutation, you might be considering a spitzoid melanoma. So definitely lining up for molecular testing. And that brings us to, before that, I would mention an HMB45. So an HMB45 should show relatively less intense staining as you descend deep down into the nevus. And then if you have any doubts, then it's good to get molecular testing. So you'd want to do FISH to look for changes in the chromosomes, gain or loss of important foci that are usually associated with melanoma, and Depending on what your laboratory offers, the foci may be slightly different, but typically it's a 4-probe fish. And then there is next generation sequencing as well. So you can do sequencing to make sure that there are no melanoma signatures in the lesion as well. So that's just an example of a Spitz nevus, and then the discussion around immunohistochemical staining as well as molecular testing. And I will post more melanocytic nevi examples as well. This was just an introductory video.